Welcome to the program titled The Hazards of Immobility Among Obese Individuals. The purpose of this presentation is really to look at the background of the hazards of immobility and the physiologic impact that patients have. We'll look a little bit at the economic hazards and then some ways for you to mitigate risk with an obese patient who is immobile. What we know is cytokines, adipokines, and other cellular messengers lead to inflammation, and this affects every cell of the body. This inflammatory state creates a toxic environment, and it affects the cardiac, vascular, respiratory, musculoskeletal, metabolic, the skin, gastrointestinal, and emotional or psychological systems. The hazards of immobility really threaten the most basic of outcomes. As early as 1947, researchers described immobility-related concerns in one of the most important medical papers to date because it really recognized the hazards of immobility at the time when bed rest was the foremost treatment for illness. Two decades later, in 1967, Olson published a landmark article which many of you may have read in the American Journal of Nursing titled The Hazards of Immobility, and this article is still regularly quoted, distributed, and discussed. What we know is hospitalization for an acute illness, even of short duration, imposes a degree of immobility on any patient. And in an adult obese patient, such immobility and subsequent deconditioning can really be devastating. A lot of facilities are beginning to plan for larger, heavier healthcare recipients. Now, what I'd like to talk about is the changing face of America in terms of size. And so we know that obesity is changing the face of the healthcare delivery. Mortality associated with obesity is arguably 300 to 400,000 annually. The rate of overweight and obesity in America is about 67 to 74%, depending on the study that we look at. And the rate of obesity in the US is 40% or more. 6.2% of Americans are morbidly obese. And we also know from point prevalence studies that 18 to 50% of obese individuals in acute care are obese. The situation's pandemic and the etiologies are really unclear. For example, York Hospital in the Northeast United States reported that 66% of their patients on any one day were overweight and 22% were obese. And most alarmingly, childhood obesity is on the rise. So what I'd like to do right now is I have a set of slides from the Centers for Disease Control. You can download these if you like and have availability to them. But we're going to start at 1985, and what we're going to do is we're going to go through all the way up to 2010. You may have seen these slides before, but what I'd like to point out today is that this reflects not only our patient population and how to plan for patients, but it also reflects the population of our caregivers. So let's move through these. We're going to stop at 1997. What's important about 1997 is that is when Tui Main did the study, and we can move through the slides up to 1997. That's when Tui Main did the study looking at the fact that the average nurse on an average 8-hour shift lifted, turned, repositioned 1.7, 1.8 times. This is 1997 here. So now we're going to move, when the Tui Main study was done, now we're going to move to 2010 and see how the population has changed since that time, and then how that has really has impacted healthcare and will impact healthcare delivery. So here's 2010, so you can see how different this is from 1997. And so we can predict that workers are not only working longer shifts, but patients and workers themselves are heavier. So let's go to the next slide. So why are the hazards of immobility more significant among patients living with obesity? What we know is since adipose tissue releases tumor necrosis factor alpha, interleukin-6, resistant and other compounds, this has an influence systemically. It specifically leads to insulin resistance, hyperlipidemia, chronic inflammation, pathological angiogenesis, and thrombosis, which collectively compound the dangers of immobility among patients of size. In the event any or all of the body is immobilized, common predictable and costly effects of care are likely to happen, and the greater degree of immobility and the longer the periods of immobilization, the greater the risk for development of these adverse outcomes. Physiologically, we've established that no body system is immune to the effects of immobility, especially in the presence of obesity. For example, consider the musculoskeletal system. Muscle strength decreases nearly 7% among all patients, but in the presence of obesity, the patient may have additional aggravating conditions such as chronic pain, arthritis, weight maldistribution, which leads to falls, and other issues. Now, when we think about economic hazards, in addition to each one of the items that you see listed here under economic hazards, let's consider the impact of immobility, obesity, and worker injury. And that's on the next slide, where we talk about the study that was done by Walt Porres, Dan Drake, and others at Pitt General Hospital and East Carolina University. We like to quote this article because what this article helps us understand is that in those respective facilities, patient with BMI greater than 35 comprised only 10% of the patient population. However, handling patients with a BMI greater than 35 was associated with almost 30% of all workers' comp injuries, almost 30% of lost time, and almost 40% of restricted time. And in this study, what was done was lifting, turning, and repositioning was done using manual handling techniques and not technology. So let's look at the next slide, where we have established the fact that we've discussed physiologic and economic risks. But let's ask that question: how do we mitigate the risks, and how do we become the solution? So in the next slide, we talk about the definition of early progressive mobility, which is the series of planned movements in a sequential manner beginning at a patient's current mobility status with the goal of returning to baseline. There are a number of, in the next slide we look at, there are a number of progressive mobility models, but most progressive mobility programs are comprised of 4 or 5 phases. The AACN, which we'll talk about, is a 4-phased approach, and this is the model that's set forth by the Critical Care Nurses Association. So let's look at the next slide, where we talk about integrating the total lift bed across the early mobility continuum. Let's take a minute and look at this 4-phase approach to early mobility. And the issue with the obese patient is managing the patient's body weight and weight maldistribution while protecting the caregiver. And therefore, this can be really complicated. There's a couple studies that I just wanted to share with you in terms of the time that it takes to engage in certain kinds of activities. One study was done by Shia, and Shia and Rose both looked at some activities. And let me just share that even helping the patient sit took an average total staff time of 40 minutes, and this is among the obese patients. So let's talk about some activities that we can provide across the continuum of care. So when we look at phase 1 in a 4-step phased model includes progressive range of motion, turning, and the ability to tilt the patient. This serves to meet the goals of this phase irrespective of the patient's weight. So we see the VItalgo total lift bariatric bed being used in this way. Phase 2 of this 4-step model seeks to place the patient passively in the sitting position where further strengthening can occur. And keep in mind, in the studies that I just quoted, the average amount of time it took to sit a bariatric patient up was 40 minutes, and you can see how different that is as compared to using technology. Standing can begin in this 2nd phase. Now in the 3rd phase, periods of weight-bearing increase, and the supported patient can begin further strengthening by marching in place or other lower or upper body activity that lead to strengthening. And then in the 4th phase, set forth by the AACN, once the patient shows tolerance in the first 3 phases, she then can ambulate away from the surface of the bed. The total lift bariatric bed is useful in each of the phases of a progressive mobility model. So let's talk about being the solution. this innovation really ensures dignity, and it ensures respect for workers and for patients or residents as well. And I just want to suggest, to learn more about this topic, I really encourage you to review the brief. And then we also have a video on bariatric sensitivity, and I encourage you to view that video because that takes this a step further in terms of what this type of technology can do for you in terms of patient dignity and sensitivity. Thank you very much.